So very good morning to one and all present here. So as we saw, NSBV, the non-strabismic binocular vision anomalies, are one of the most important causes for headache. So today we'll be dealing about the clinical assessment of convergence, fusion, and accommodation. So first we'll be talking about convergence and fusion. Convergence can be either voluntary convergence or involuntary convergence. So under involuntary, proximal convergence, that is the instrument convergence, or because of the proximity of the object of regard, we have some amount of convergence. That is called as the proximal convergence. Fusional convergence or the positive fusional convergence occurs because of a bitemporal retinal disparity. So this fusional convergence is what we are improving by the orthoptic exercises. What is this bitemporal disparity? Suppose if we have an object which moves from distance to near, both the rays are falling on the temporal retina. So that is the bitemporal disparity. So now to focus the rays on the macula, both the eyes start converging. Next is the accommodative convergence. So the convergence that occurs when the eyes accommodate is called as the accommodative convergence. And the last is the tonic convergence, which is the inherent innervational tone of the extraocular muscles, and it is prominent in childhood and decreases with age. So the clinical assessment of convergence can be the near point of convergence first, followed by the fusional vergence and then the vergence facility. So first, near point of convergence is the closest point at which the object can be seen singly. It can be assessed using plastic ruler, Prince ruler, RAF ruler, or the Livingstone binocular gauge. We'll be dealing in detail about RAF ruler because that's the most commonly used. So RAF ruler or the Royal Air Force ruler was initially used in UK in the mid 1950s to assess the convergence and accommodation of people who were employed into the UK Army for clerical purposes. So it is a 50 centimeter metal ruler. Why 50 centimeter is because it allows for the measurement of the NPC and NPA of even presbyopes who prefer to read at 40 centimeter or more. So there are 4 target drums in the RAF ruler. The first one being the reduced Snellen chart. So this is reduced to 1/17th of the actual size, and it subtends an angle of 5 minutes of hour, which is the same as what the distance Snellen chart also subtends. The second drum is a section of the GPO directory. The third drum is the Times New Roman typeface with standard spacing N5, N8, N10 and N12 font sizes. The fourth is a dot on a line. This drum is used to assess the NPC, whereas the other 3 drums are used for assessing the near point of accommodation. And there are 4 sides to the square rule. So one side has a centimeter and 1 centimeter increment, and the other has a dioptric equivalent. The other is the age scale, and the fourth side indicates the scale, which shows the normal and the abnormal convergence. To record the reading, the measurements have to be taken from the rearmost edge of the slider, and this cheek rest, which is about 6 centimeter, can produce an error in measurement that we cannot go beyond it. So this error is compensated by projecting the target forward by 6 centimeter. So first, to measure the NPC, we have to depress the RAF ruler by 45 degrees and move the target drum at a constant rate of 1 centimeter per second. Subjectively, we can also see that the patient is converging both the eyes, and we have to ask the patient when they are seeing double. And the readings are noted to the nearest 0.5 centimeter and have to be repeated so that we can check for the fatigue or maintenance of the convergence. So the Prince ruler is also there. It is 24 inches long. The next is the testing fusional Vergence amplitudes. So Vergence amplitude is the ability of the eye to maintain binocular single vision when we are presenting it with varying levels of binocular demand. So there are 2 types, the positive fusional or the fusional convergence, and the negative fusional vergence or the fusional divergence. It is done with the help of prisms because prisms shift the image of the object. So we know that the ray of the light is going to be shifted towards the base of the prism. So this will create a vergence demand. There are 3 types to test the vergence: smooth vergence by using a phoropter, the step vergence testing using a prism bar, which we mostly use, and the jump vergence testing, which is rapidly changing the prism power. So positive fusional vergence, we are going to test the fusional convergence. We have to use base out prisms for it. So we can remember that the second letter of the word, the convergence, will be the same as that of the prism that we are going to use. Similarly, for negative fusional vergence or the fusional divergence, it is the base in prism that we have to use, the prism bar. So how base in prisms test for divergence? So let's see what happens. This is a normal eye, and we are going to place a base in prism. So what is going to happen to the ray? It is going to be deviated towards the base of the prism. So this is the ray. Now the patient wants to fix with the right eye. and brings the macula towards the ray. So there is going to be an outward deviation of the eye. So according to the Hering's law, the other eye is also going to deviate inward. But now as the patient appreciates diplopia, he refixates. He uses his fusional divergence to bring the ray back on the left eye fovea. So this is a Vergence movement. So base in prism, although the eye under the base in prism is in exotropia, it induces an esophoria in the other eye so that we can test for the fusional divergence of the eye. So this is the procedure. Always the negative fusion vergence is tested before the positive fusion vergence. And here we can see that we are using base in prisms. Slowly the prism bar is moved in front of the eye. If the patient is having any refractive correction, they have to wear it fully. And the target is shown. They have to say whenever they are seeing diplopia. So closely, if we notice when we are slowly increasing the prism, we look at the other eye, we can see the refixation movement happening. So yeah, at 14 we saw it. So similarly, we have to keep reducing the prism to find out the refixation point. So first, what happens when we keep the prism bar is there is an initial retinal disparity which we saw. So this small deviation can be fused till the patient has the fusional divergence amplitude. So once it is exhausted, the patient now is seeing it near. So he is accommodating. So what the eye thinks, okay, let me relax my accommodation so that the accommodative convergence will get reduced. So I can diverge my eye a little more. So when he relaxes the accommodation, he sees the blur point. Following that, he appreciates diplopia, that is the break point. And when we slowly decrease the power of the prism till the fusion occurs, that time we notice the recovery point. So now we're going to see how base out prisms are used for testing the convergence of the positive fusional vergence. So this is the normal light. And we keep a base out prism in front of the right eye, and we can see that the ray move towards the base. And when the patient uses the right eye to fixate, it moves inward. There is going to be, according to Hering's law, there is going to be an outward movement of the other eye. So when the patient refixates, it is again going to be an esotropia. There is going to be convergence movement. So base out prism actually induces an exophoria in the other eye so that the patient will use the fusional convergence to bring it back. Whereas the eye under the prism will actually look nasally deviated and esotropic. So here also there is going to be a blur break and recovery point, but the cause of blur here is because the patient is exerting more accommodative effort. So once the fusional convergence is exhausted, next to use is the accommodative convergence. So this accommodative effort is excess of what is required and that causes the blurring. So that is the blur point here. So here we can see we are increasing the base out prisms in front of the eye. We have subjectively the patient also says when they are able to notice double vision, and objectively we can also note in the other eye for the recovery movement, the refixation movement. So initially they might be able to fuse a little, so we have to wait till they are seeing it as the sustained blur is seen or the sustained diplopia is seen. So and we have to reduce it back to find out the recovery point. So the normal fusional vergence reserve for near, mostly when we test, for convergence is 25 to 30 prism diopters, and for divergence is 8 to 10 prism diopters. So next is the Vergence facility. So Vergence facility assesses the dynamic capacity of the fusional vergence. We are going to present the patient with 3 prism diopters of base in and 12 prism diopters of base out alternatively. So the patient has to wear full optical correction. It is done binocularly. We have to start with the base in prism so that we can relax, then followed by the base out prism. So we have to keep flipping the Vergence flipper alternately. One base in and one base out together is 1 cycle. This is repeated for 1 minute and the number of cycles per minute is assessed. So normally it is around 12 cycles per minute that they have to read. Whether it's clear or till it becomes clear, we have to wait. So once they say it is single and clear, then we can do the flip. So the number of cycles per minute and the difficulty noted with which prism is also important. If they have difficulty to clear the base in prism, base in produces divergence. So if they have a difficulty with base in, then it means they have a divergence insufficiency. Similarly, a difficulty to clear the base out prism will be seen in convergence insufficiency. So next we move on to accommodation. So what is accommodation? When from a distance, the rays come parallel rays. So when they come to a point of focus on the retina, the same stimulus when it's coming from near, there are diverging rays. So the rays are focused behind the retina, and what our eye does, there is going to be an increase in the curvature of the lens so that the rays are brought back onto the retina. So this is accommodation. The clinical assessment of accommodation is done by first the near point of accommodation, which is the closest point at which the small object can be seen clearly, which is also called the near point or the punctum proximum. It varies with age. Unlike NPC, which is always like normal within 8 to 10 centimeter, NPA varies with age. It can be done by using an RAF ruler. Start. So similarly, the patient has to wear their existing refractive correction. First, it is done monocularly, then binocularly. So the target drum can be moved forward 1 centimeter per second, and whenever they are noticing blur, the value has to be noted. It has to be repeated 3 times. NPA varies with age, and it has to be correlated according to their dioptric correction and the age also. So suppose if we are using this target, the Times New Roman font as we saw, for the N5 target can be taken, and for right eye, the word on the right hand side, the every, or on the left side, the custom, or for both eyes, the word the can be taken for noticing the blur. So next is amplitude of accommodation. The maximum amount of accommodation that an eye can exert is called as the amplitude of accommodation. So it gradually falls with age. There are many ways of recording the amplitude of accommodation. So first by RAF ruler, if we can find out the near point of accommodation, like this is in centimeters, we can correlate it with the dioptric availability, which is there on the other side of the RAF ruler also. So, or if we know the NPA, we can also use the formula like amplitude of accommodation is 1 by the near point of accommodation in meter, or 100 by NPA in centimeters. So if we can see if it is a 10 centimeter was the near point of accommodation for the patient, 100 by 10 will be 10 diopters. So the amplitude of accommodation will be 10 diopters for the patient. So another is the Hofstadter's formula. Minimum amplitude of accommodation will be 15 minus 0.25 into their age. Similarly, the average and the maximum amplitude of accommodations are also given by the Hofstadter's formula. And amplitude of accommodation by minus lens method. So what happens to accommodation when we keep a minus lens method? So first let's understand that. So this is from a target, we are having the rays falling on the retina. Suppose if we keep a minus lens are diverging lenses. So they diverge the ray and the ray falls back behind the retina. So now what will the eye do? It wants the rays focus back onto the retina. So it will start increasing its accommodation so that the rays fall onto the retina. So whenever we keep a minus lens, the accommodation is stimulated. So this is the method. So the patient has to focus on a 33 centimeter near target with existing correction and one eye is occluded. We have to introduce minus lenses in steps of 0.25 diopters. The second lens is placed before removing the first lens. And the first point of blur will indicate their limit of accommodation. So how much ever minus they are able to accept, that we have to take. Apart from that, wherever they are holding the target, suppose at 33 centimeters they are holding the target, 100 by 33, there is 3 diopters of accommodation is already acting. So that amplitude also has to be added to whatever minus that we have calculated. Suppose if it is 40 centimeter, then 2.5 diopters has to be added. Next is the amplitude of accommodation by Donner's pencil push-up method or the pencil push away method. So here a full optical correction is given, and the patient has to focus on the target. When they notice the blur, we have to note the near point of accommodation on the scale which is placed on the lateral canthus. So monocularly it is done 2 times for each eye, and then it is done for binocularly. So similarly, push away is from near the eye, we start pushing the target away from the eye. So among the other methods, RAF and push-up usually overestimates, whereas minus lens method underestimates the amplitude of accommodation. Next is the accommodation response, which can be done by monocular estimation method or the knot retinoscopy. So in monocular estimation method, we measure the accommodation response on seeing the near target at 40 centimeters. So the patient sees the target and we have to do the neutralization by using the retinoscopy. So normally there will be a lag, slight lag of accommodation of plus 0.25 to plus 0.75 will be used to neutralize. Knot retinoscopy is also similar to the MEM retinoscopy, but there instead of neutralizing the lenses, here we have to move the streak retinoscope forward and backward. If there is a with the movement seen on the retinoscope, we have to move away from the patient. If there is an against the movement, we have to move towards the patient. So next is the assessment of dynamic accommodation, that is the NRA and the PRA values. So what is NRA and PRA is that we are assessing the maximum ability to stimulate or relax the accommodation, which is done under a fixed convergence. That's why it's called relative at a particular distance of 40 centimeters. So positive relative accommodation, wherever there is positive, it means we are increasing the accommodation. So accommodation is stimulated. So as we saw, accommodation is stimulated by minus lenses. And negative relative accommodation is when the accommodation is relaxed with a plus lens. So similarly, we see what will happen when there is a plus lens placed in front of the eye. So from the target, rays are coming and focusing behind the retina. So now when we place, so this is what happens when there is accommodation. Normally when there is accommodation, the rays are brought back to the retina. When we keep a plus lens, we are supplementing converging power from outside itself. So that will increase the converging power. So now our eye will think, okay, it is too much converged. So let me relax it a little bit. So the accommodation is relaxed. So whenever we keep a plus lens, it relaxes the accommodation. So first we'll be doing the NRA. The trial frame with the patient's existing correction is kept. And patient has to focus at the N6 target at 40 centimeters. Plus lens will be slowly added in increments of 0.25 till there is a first sustained blur. So the second lens should be placed before we are removing the first lens. So here for this patient, we are achieving it at 2.5. Then slowly we are reducing now. Again, it has to brought back to normal. So 1.75 will be placed before removing the 1. And then 0.5 will be placed before removing the 0.75. So again, it's brought back to normal. Then we have to start doing the positive relative accommodation. So in PRA, positive relative accommodation, we have to place minus lenses. So slowly in increments, we have to keep placing the minus lenses till the patient sees the sustained blur. So the normal NRA value is plus 1.75 to plus 2.5 diopter sphere, and PRA value is minus 1.5 to minus 2.5 diopter sphere. So the last is the accommodation facility or the accommodative rock. So this is the ability to change the focus, that is from far to near or near to far. So how well the patient is able to use and relax their accommodation alternatively. So these are the rock cards available at various font sizes like N8, N12, N18, and these are the flippers available in various diopters. So first we have to do monocularly, then binocularly. We have to start with the plus lens so that we can relax the accommodation, followed by the flip to the minus lens. So once the patient reads the first the word on the box and it's clear, then we have to do the flip and they have to read the next word of the box. So once the patient clears the blur which is induced by the lens, then we have to ask them to read the next word through the next lens, through the flip. So monocularly, 15 cycles per minute is normal, and binocularly, 12 cycles per minute is normal. So we are waiting till they are noticing it single and they're able to read the word clearly. So here also we have to note with what lens they're having difficulty, whether it's a plus lens or the minus lens. So last is the relation between accommodation and convergence. So as you all know, it's the AC by A ratio. That is the amount of change in the convergence for an amount of accommodation that occurs. So the unit will be convergence is measured in prism diopters and accommodation in diopter. So the unit is prism diopters per diopter. And the normal will be 3 to 5 prism diopters of convergence for every 1 diopter of accommodation. So when there is a high AC by A ratio, eyes tend to overconverge for a given amount of accommodation, producing esotropy of an ear. Low AC by A ratio produces exotropy of an ear. And the basis behind measuring the AC by A ratio is you change the patient's accommodation, you measure the associated convergence with the prism and alternate cover test. So this will help us to calculate the AC by A ratio. So how can we change the patient's accommodation? Either we change the fixation distance or we change the amount of accommodation by using lenses. If we change the fixation distance, it's called heterophoria method. If we use the lenses, it's called the lens gradient method. And the rules to know is that the patient has to wear full optical correction and use proper accommodative target and also take care of the fixation distance 6 meter and 33 centimeters. For all calculation purposes, esotropia is taken as plus and exotropia as minus. So in lens gradient method, it can be done for distance or for near. For distance, we have to measure the deviation without the lens at distance. So at distance, we're not going to accommodate. So whatever we measure without the lens will be the deviation without the lens where the accommodation is at rest. So to induce accommodation, as we already saw, to stimulate accommodation, it will be the -3 diopters lens. So after placing -3 diopter lens, again we have to see the deviation. So that will be the deviation with the lens. For near, the deviation without the lens will be the deviation where the accommodation is in action, because at near, accommodation is already in action. So when we place the lens, we have to relax the accommodation, and that lens will be +3 diopter lens. So the formula will be deviation without the lens minus the deviation with the lens divided by the lens that we have used in diopters. So for near, if the deviation is ET 40 prisms with +3 diopter lens, because here accommodation was there. So now to relax the accommodation, we use +3 diopter, as I told. So here the accommodation is relaxed and the ET also will relax. So there will be ET 10 prisms. So AC by ratio will be, ET is always plus. So it will be 40 minus 10 by 3. So it is 10 prism diopters per diopter of accommodation. For distance, if we see exotropia 4 prisms was there, and exo we have to take it as minus for calculation purpose. So deviation with the lens, we are using a -3 diopter because we need to stimulate the accommodation here at distance. So it becomes ET 14 prisms. So deviation without the lens, that is -4, minus of +14 because it's ET, divided by the lens that we have used, that is a -3 diopter lens. So it will be 6 prism diopters per diopter of accommodation. Next is the heterophoria method. So AC by ratio is equal to the IPD plus near minus distance by the diopter that we have used. It is simply like always near minus distance. So here the diopter that of accommodation that is used is also near minus distance only. But for distance, it is going to be infinity, where we're not going to use any accommodation. So 1 by infinity is going to be 0 only. So there is nothing, almost like 3 minus 0. So it's directly written as deviator of accommodation for near. So this heterophoria method is dependent upon the interpupillary distance, and that is why heterophoria method measures the proximal convergence as well as the accommodative convergence. So suppose at distance we have an ET of 10 prisms, and at near we have ET 40 prisms, and the IPD in centimeters is 5. So AC by ratio will be 5 plus near minus distance by the diopter of accommodation for near. So because it's 33 centimeters, we have used 3 here. So there we use 3 diopter length, so we had the denominator as 3. But here, because it's 33 centimeters, it's 3 diopters. Suppose if it was 40 centimeters, it will be 1 by 0.40, there is 2.5 diopters only. So there is also something called PC by A ratio. There is a proximal convergence to accommodation ratio. The normal will be 1 to 3 prism diopters of proximal convergence for every 1 diopter of accommodation. So this can be found out by subtracting the AC by ratio by heterophoria method and AC by ratio by gradient method. Because heterophoria measures both, as we saw, and gradient method measures only the accommodative convergence. So here, this is the lens gradient method. We have used and found out the AC by ratio to be 1.7:1. In heterophoria method comes for the same values for the same patient, it comes as 8:1. So which implies that the difference between both of it, that is 6.3, is the PC by A ratio. So I know this is how it is now after all this. We'll have a live demonstration today evening after the Kahoot quiz. I would like all of you to join there. Thank you.